Kamlesh to join me on the dais. So I will request Dr. Ankur to speak on role of muscle transposition in Strabismus surgery in current scenario. Dr. Ankur, please.
Very good morning. I think the first session we are here, and I'll start straight away with the role of true muscle transplantation. So large angle strabismus is always a challenge, and there is a need for multiple surgeries. Alignment may be unsatisfactory when we are operating one eye, and patient may need actually other eye surgery. And sometimes patients are reluctant to undergo, more so if the involved eye is a myopic or is the only squinting eye rather than a free alternative strabismus. So like this is a patient who had a large angle esotropia, underwent a maximal recession resection and is grossly unsatisfied. Also he is unwilling to undergo surgery for the other eye because for him the right eye is the only squinting eye. So in the current scenario, patient-doctor relationship has actually changed. Leaving an unsatisfied patient is disastrous for your practice, medico-legally, and in all possible ways because they can trouble you. So informed about the alternatives, let them choose and make them a party in their decision. So like this is a large angle strabismus. Again the same challenge. There are two options. Either we go for a bilateral surgery in one go or one eye followed by another eye, which is again a bilateral surgery. And this probably has a better chance of having full range of movements. But what if the patient doesn't want the surgery in the other eye? So we look back the literature. The oldest mention of transplantation was in 1973, where the free transplantation of muscle as an experiment was performed in dogs as well as in humans. And what they found out was that transplanted muscle survives and remains viable. However, there are certain changes. Like gradually there is a fibrous replacement of the muscle tissue, and it does not incite any reaction from the recipient muscle or the sclera. The tensile strength of the transplanted muscle is equal to the repaired muscle wounds, and union of the transplanted muscle to the sclera and the recipient muscle is strong enough after 14 days or so. And these are two articles in the literature where this has been done for large angle esotropias, and both of them reported acceptable alignments post-surgery. And both of them are from India. So this is a patient which I had shown you, 18-year-old male, 6x6 OU, 80% diopters of esotropia, no significant refractive error, and refusing left eye surgery now and in future. At least at present he's saying that I don't want to get my left eye operated ever. And this is the 9 gazes. There is hardly any oblique overaction or any A or B pattern. He is just a simple case of esotropia. So this is the surgery which we do. We first start the lateral rectus because the transplanted muscle has to be first removed from the site, I mean the free muscle. So this is the 6-0 vehicle which is being passed at the insertion of the lateral rectus. So in the transplantation we do the initiation of resection first and then complete the recession. So this is the first muscle, the lateral rectus, which is around 9 millimeters, and this time we are passing the sutures from the posterior part of the mark so that we attach this muscle to the sclera. So the anterior part would be taken as the muscle stump and the posterior will be attached to the sclera. So this is the disinsertion from the, cutting of the muscle, and then this is the disinsertion from the site of original insertion of the lateral rectus, and this is the muscle stump we get. So this muscle stump is being transplanted to the medial rectus. We pass the sutures of the lateral rectus from the muscle stump, but we don't tie them, because if we tie the muscles, then it is going to be a very tight eye. And this is the medial rectus which is being exposed. And again we pass the sutures, but this time we are passing non-absorbable sutures because it takes approximately 2 weeks to actually have a good strength. We can also use 6-0 vehicle, but I was a little worried about the suture giving way earlier than the muscle getting the strength. So this is the 4-0 ethibond being 5-0 ethibond being passed through the muscle stump, and then the anterior part of the medial rectus and the posterior part of the resected lateral rectus being tied. So we have to make sure that this junction is very snugly connected. There should not be a gap or sagging in between the two parts of the muscle. So this is the resected muscle of the resected part of lateral rectus being attached to the medial rectus, and then we do a 6 mm recession. So this becomes a very long recession if you look in that terms, because 6 plus another 6 or 7 millimeters of lateral rectus have been taken into account, and this is the recession of medial rectus, and that is the original medial rectus behind it, which is attached to the transplanted muscle. And then we tie this suture, the lateral rectus. We find a little bit of sag here, so we are taking another bite from the lateral rectus to avoid this sag of the muscle, and then that finishes up the surgery. We close the conjunctiva with 8-0 Vicryl. So this is the post-operative day 1 results, and we can see there is significant amount of underaction on the adduction of the right eye, because we have done a supramaximal recession of the medial rectus. So as the time passes by, the patient does gain some amount of adduction, which is better than first post-op day. Still there is -1, -2 kinds of deficit left in the adduction. So to conclude, true muscle transplant may be a viable option in large angle esotropia, especially when the patient is refusing other eye surgery. It is more so in amblyopic eyes and the permanently squinting eyes. And it does not give rise to a significant incompetence as you would expect for large recessions. And one need to accept some amount of adduction limitation in these kinds of surgeries if we are planning. Thank you.
Thank you, Dr. Ankur, for a nice presentation. How many what is the series in which you have done this sort of?
Sir, I have done around 5 cases, 5 or 6 cases. 2 of them didn't do very well.
Okay.
They actually had a large angle still remnant, so I'm still, continuing my series. So it's a viable option. We can always give an option to the patient that you have to accept. Like this patient was very adamant that I would not get the left eye operated ever.
And what is the maximum amount of deviation corrected by this procedure?
Sir, what I have seen is around 80 prism diopters can come with this surgery, not more than that.
Would it not be better if you would put the lateral rectus on adjustable?
Lateral rectus resection on adjustable?
No, after you've done the resection, because you have some degree of unpredictability, na? How much that resected portion which you have transplanted will work.
That is true, that is true. We actually get around 6-7 millimeters of the muscle which we actually transplant. I was apprehensive because we had already resected the lateral rectus by 9 millimeters, which is actually maximum. You can do 1 millimeter more, but we are already anticipating adduction deficit, and if you do a larger resection, then you will have more adduction deficit, or even the muscle can also get weaker, because if you are going into the muscle tissue rather than the tendon, then the muscle lateral rectus will also get weaker. So you can have more unpredictability with going beyond that. So you've already placed it in a 9 millimeter resection and you put it on adjustable. So you can further you can reduce the amount of resection.
Yes.
Not
that's
so
you didn't get any
overcorrections. Yeah,
you didn't get any exotropias.
No, we didn't get any overcorrections. We all got, both the patients which were having esotropias rather than the exotropias.
Thank you, Dr. Ankur.
Thank you.
Now I invite Professor Pradeep Sharma to speak on resurgery in strabismus prevention and management.
Thank you, Professor Dadia. Yeah. Achha, that side you put it. Here also. I thought alternate kar rahe ho, to idhar karo. It's there, but it's coming from middle. So, good morning, people. I think it's a early breakfast session, and so we have a very few attendants. Hopefully, next time we'll have more. We have to see why things go wrong and how we can prevent the resurgeries. There can be errors of omission or errors of commission. Errors of omission can be by a misdiagnosis or faulty planning, and errors of commission are the surgical mishaps, which are some of them avoidable and some are unavoidable. In strabismus, the question of spot diagnosis and spot surgery is a disaster. You have to observe, confirm, infer, plan and execute. That is the recipe that we follow, OCIPE, in order to have a proper result. The perils which can be there in improper diagnosis, you can jump to a conclusion that it's esotropia, which may not be true, or an exotropia, which may be a pseudo-eso and exotropia. Secondly, you have to ensure that you have given a full cycloplegic prescription before you jump to a surgery. It may be simple accommodative or a partially accommodative esotropia. for which glasses alone would have worked, and surgery would obviously result in a later on some overcorrection. Again, when you are examining, it's important that you have the accommodative targets, otherwise you will not get the full accommodative amount that you see. Prism cover test has to be done, not the Hirschberg's measurements, and whenever you are using prisms, you do not stack the prisms one over the other. Remember, it's like in Hindi we say do or do panch. It's not 2 plus 2 is not 4, it can be 5, and that's what happens in these cases. And in glasses, whenever there are thick glasses worn by a child, it's important to understand there can be an induced prismatic effect in measurement, so you have to be careful about this and use the nomograms wherever you have such a problem. Then the squint can vary with the divergence fixation and the near fixation. There can be divergence, excess, convergence, insufficiency type of exotropias. We have to be careful about the safe limits. The eyeball, which is in infants much smaller, is going to have much more result, and so there are to be these are to be respected. The functional equator, as we know, in the medial rectus is anterior 2 millimeters compared to the lateral rectus, so we have to have lesser amounts of limits for the MR compared to the lateral rectus. In intraoperatively, the perils can be splitting of the muscle sheath rupture, loose sutures or loose knots, central sag, or a slipped muscle, partially slipped muscle, lost muscle, and orbital fat prolapse. These are mostly avoidable by a proper technique. When you are measuring the amount of recession or resection, it's important that whenever we are doing whatever we are holding, it will deflect the point of measurement. So you should always measure from the point which is virgin and not been handled by your forceps. Avoid the faulty measurements by having a large arc measurement for that. Now we just have a case of restrictive exotropia. It was a consecutive exotropia, and when I opened up, I found there was a lot of fatty tissue in that, and so we do exploration of this, and we find that this fat is being removed. The interesting part is surgery was attempted but never done, so these things also happen in our country, and the fatty tissue which has caused the consecutive exo has been removed, and the muscle sheath has been spared, and we can have a proper correction without doing anything more. Another case in which there was a consecutive exotropia with a left adduction deficiency, if you see here with the arrow, there is a marked adduction deficiency, there is a exotropia, and in this case again when we opened up for resurgery, this was the medial rectus being, it was a recessed MR, and we are exploring the medial rectus, and what do we find here? We see that there is a stretched scar. Adhesions are there and the stretched scar is there, so we can, the normal muscle is behind, the scar is having a stretched effect, and so we are going to, now the measurements are showing that it is a recessed muscle and it's having effect more because of the fact that, so in such a case we would like to do a resection with advancement, and we can timely do it, and we can also do an adjustable on this for having an insurance of the alignment that we want to give. So a partial resection along with an advancement for the recessed muscle in such a case can be done, and that is what has worked. As you see here, this is the pre-op picture, and this is showing you the adduction improvement which is there. The third case which I would like to show you is a slipped lateral rectus which was explored and we had advanced. In this case there was a, now when you have during the surgery a slippage, it's easier to find at the same time. Sometimes when you have later on a case which has been referred, and when you explore for that, you would have to look. Now adhesions again are signs of the surgery which have been done earlier, and we dissect that, clean that. Part of the result will come by just our proper dissection. And after this we are looking for the lateral rectus. It has been slipped, but fortunately because the lateral rectus has the inferior oblique behind, it gets sometimes saved by this anchorage of the inferior oblique, and that is what has happened in this case. We find that the lateral rectus is there close to the inferior oblique. Some part of the lateral rectus is still possible to be salvaged. This is the inferior oblique being hooked separately, and that's the lateral rectus. So we separate the lateral rectus, pass the sutures. In the forceps now I am holding the inferior oblique. So you neatly separate the two muscles, pass the sutures in this, and then you can advance it. Slipped LR before and after advancement in this case, as you can see. Sometimes there may be a slipped muscle, and what we have to do is basically use the transposition procedures like the Nishidas in this case that we had done. So this was what you see here. Once we explored, we didn't find, then we have used the superior and the inferior rectus, and we have marked 8 mm from the insertion of the superior and the inferior rectus. We are using non-absorbable sutures and fixing it in the place of the missing muscle. These are 5-0 ethibond sutures which are being used, and this is the modified Nishida's procedure which we have done in this case. And this is after the surgery. There is still an adduction deficiency. Reoperations, whenever we have to be careful what has been done. This was a case which was done anterior nasal transpositioning. We explored and corrected it. Similarly, there may be missed obliques sometimes which we have to handle. Tight FDT is important to do before any surgery. If there is a tight FDT, you can recess and ensure that the tight FDT is corrected. And sometimes there is an under, or sometimes there is an overcorrection which we have to address. So I would like to end my talk here. Thank you so much.
Sir, is there any role of antimetabolites in resurgery?
Yes, whenever there are a lot of adhesions in resurgeries, then we have used mitomycin C, and in resurgeries we can apply a swab dabbed in mitomycin C 0.04% or 0.02%, and that can be applied for a minute so that we can have no, the effect we have analyzed, we have seen this effect lasts for about a month.
Any questions to Dr. Pradeep Sharma? Thank you, sir.
Thank you.
Now I invite Professor Kamlesh to speak on a novel technique for management of inferior oblique overaction.
Good morning, everybody. I think this is my choice of surgery for the inferior oblique, which I keep telling for last many years. Now the inferior oblique overactions, the diagnosis is very easy. When you ask the patient to adduct the eye, you can see the overacting inferior oblique. It must be differentiated with the DVD. Inferior oblique overactions, it can be either primary or the secondary. Primary associated with the congenital esotropia in around 72% of the cases, and accommodative esotropia 34%, and IDS 32%. So you can see how much, what is the incidence of these inferior oblique overaction in these cases. Asymmetric may be unilateral at onset 23%, and usually associated with horizontal deviations in the form of V pattern. Now, the primary overaction of the inferior oblique not well understood, but maybe due to the mechanical causes, innervational causes, mechanical and the innervational causes. Secondary overaction of the inferior oblique is due to the paresis in the form of paralysis of the antagonistic superior oblique muscles. These are the categorization of the overactions, but what I follow is just measure the preoperative deviation in the form of prism diopter, and then we decide how much amount of the surgery has to be done. Now the indication of surgery is the presence of sensory problems in the form of the requirement of the normal binocular vision, and as well as the cosmetic problems. Overall, this is a clinically significant inferior oblique whenever you have to have weakened the inferior oblique muscles. The common conditions for inferior oblique recessions is V pattern with the inferior oblique overactions, secondary inferior oblique overactions, maybe secondary to the superior oblique SR palsy. Duanage retraction syndrome upsuit with the inferior oblique overactions or may be associated with the inferior oblique with the DBD, etc. These are the cases where you can see while they are adducting the eye, you can see the inferior oblique overactions in the adducted positions. This is again the V pseudotropia with the inferior oblique overactions. Yeah. Now the various inferior oblique weakening procedures are myectomy, disinsertion, conventional recession, denervation, and the extirpation, anterior positioning of the inferior oblique. Now you see all these gives the various variable results, and the techniques of the recession required surgical landmarks you have to remember best on the lateral rectus or the inferior rectus, and even after that there is a no gold standard. These are the various parameters which you have to remember, and these are the reports by the autopsy reports for the different amount of the inferior oblique recession, conventional recession. So this is the, how much time do you have for me? You can have this. Just in brief, this is the conventional inferior oblique recession. I'm not going to show you detail, but my main motto is just show my procedure, but this is conventional recession that I can say just to realize that how much complication that it can give rise during the surgery and the postoperatively. After making an incision into the conjunctiva, gradually I first identify the inferior oblique, a little bit dissection up to this posterior end. Here you can see the sclera has been visualized, and then you pass the hook. That's the different way to isolate the inferior oblique by different people. But if you do like this, that will be more, yeah, you can see this is the triangular space of the sclera. Again, the separation of the posterior part of the subspacious and now this is completely dissected out. Now what I do, I pass the suture 3 mm apart from the insertion, the 6-0 vehicle sutures, double arm sutures. It should not be stitched, otherwise that may lead to the macula is very near to the insertion of the inferior oblique. Now the time is for the identification of the inferior rectus. Sorry, the lateral, inferior rectus. So here I am showing the 10 mm recession of the inferior oblique, and the point of the anterior end is 3 mm horizontal and 2 mm vertical, and that is the point where you have to insert the interior part of the inferior oblique muscles. So all these landmarks we have to remember during this conventional surgeries, and a very fine surgery, very surgical procedures should be carried out to avoid so many things. So with this, the complications which can be there with the inferior oblique recession surgery, incomplete division of the insertion, width of the muscles, inadvertent cutting of the LR or the IR, parafoveal scotoma, adherence syndrome, or the internal ophthalmologia, and sometimes postoperative hypertropia. Now, the hangback muscle recession surgery, as you know, technique for the inferior oblique is not done for the oblique muscle surgery before. Why? Because it is aphasia, less tendinous, and do not retract like recti. We believe that the inferior oblique muscles will retract into its seat and shall stay recessed according to the amount of the recession done. So this is my procedure which I used to do, the suspension recession techniques. The isolation is the same way as I have done for the conventional. There is no other route. But in this we give the very small incision in order to not to damage its sheath of the inferior oblique much. So passing this suture 4 millimeter away from the, in place of 3, 4 millimeter away from the insertion. Again the double arm 6-0 Weichel suture, and then 1 meter away. Here we have to make a loop and we cut it here. And you can do the recession as much as you can by measuring the sutures, right? This is a 10 mm again. Yeah, that's it. So these are the comparative results of the various surgery. We have done the initially the recession, conventional recession, and compared with the hangback recession, you can see the success rate is 90% in the cases of conventional recession and 93.3% with the hangback recession. All these published in the various index journals. These are the pre-operative and the post-operative results. Again, this is you can see the pre-operative and the post-operative results. They're very good. So, advantage of suspension resistance technique is the landmark-free surgery and minimal with the manual manipulations, easily gradable from 6 to 10 millimeter, very fine quantitative control over the muscles. Muscle is always available for later re-exploration and adjustment. No doubt with the satisfactory results, no advertent perforations, less chances of snaring of the Tenon's capsule, and there is always the provision for the intraoperative and the post-operative customizations. Thank you very much.
Any questions to Professor Kamlesh? Thank you, sir. Now I invite Dr. Subhangi Bhave to speak on fourth nerve palsy analysis at a clinical setting. Dr. Bhave, please.
Good morning, everyone. I thank the AIOC for asking me to speak on this topic, and also thanks to SPOCI for asking me to speak on this subspecialty. I'll be presenting in small data of analysis of trochlear nerve palsies done at a clinical setting. Now the aim was to study the pattern of trochlear nerve palsy in clinical setting in central India, to know the clinical presentation and associated deviations in congenital and acquired palsies, and to assess the surgical results in patients who required surgical correction. Now, fourth nerve palsy we know is in commonest trochlear nerve palsy found in Strabismus clinic. In children, the most category of fourth nerve palsy is congenital, and in adults, trauma and ischemia are the leading causes of fourth nerve involvement, and the other causes are infrequent. And the commonest presentation of this condition is a hyperdeviation of the affected eye and abnormal head posture, including head tilt to the contralateral side, as in this case, who presented with left hypertropia had a head tilt to the right side. The superior oblique palsy, which remains there after 6 to 8 months, would require surgical correction. This was a retrospective analysis of patients of superior oblique palsy, both congenital and acquired, attending Drishti Eye Clinic and Squint Center between January 15 to December 2016. We analyzed 54 subjects, 12 were excluded as they were lost to follow-up. All the clinical assessment and surgeries were performed by single pediatric ophthalmologist. Vision, anti-segment and fundus were examined in both the eyes. Fundus was also examined for torsion. Squint assessment was done, and presence of facial asymmetry and abnormal head postures were noted. The subjects were diagnosed based on clinical examination by the Parkes 3-step test, which we all know that the first thing we do is to see which eye is hypertropic, which reduces it to 4 muscles. Then we see in which direction is the vertical deviation more, which reduces it to 2 muscles, and then we see when the hyperdeviation increases on head tilt to the right or left shoulder, which brings it down to a single muscle. So in this example, it would be the left superior oblique muscle. If the hyperdeviation, left hypertropia increasing in right gaze and increasing on left head tilt. When one has to examine the extraocular movement, you can see in this video, there is no deviation in the left gaze, but in the right gaze there is a hypertropia of the left eye, and there is an underaction of superior oblique muscle, and this increases in the left head tilt. The Hess charting gives an valuable assistance in knowing the position of the eyes, as in this case there is underaction of both the superior obliques asymmetric with overaction of the inferior obliques. So it's a case of bilateral superior oblique palsy. There is also an excyclodeviation. Then on table we do an exaggerated force junction test, that is we retropulse the globe in the orbit and see for the laxity of superior oblique tendon, which helps us in deciding the surgical option. So this is seen commonly in cases of congenital superior oblique palsies. The selection of operated muscle procedures were based on the recommendations, and the procedures chosen were, the most common was inferior oblique recession, the tucking of superior oblique, inferior rectus recession, and Harada-Ito procedure. Here I would be showing a very small clip of the Harada-Ito procedure, because rest of the procedures it's not possible to show the clips. So in Harada-Ito, we know that there's a superior oblique has 2 components, anterior 1/3 for the intorsion and posterior 7/8 for the posterior 2/3 for the depression. So wherever there is in acquired palsies, there's an excyclodeviation. We want to weaken that portion of superior oblique. So the 1/3 portion, anterior 1/3 slip of posterior of the superior oblique muscle is dissected, and it is attached 8 millimeters behind the superior border of lateral rectus, which reduces the excyclodeviation, and this can be also put on attestable. Now the results of a study was there were about 40% females and 60% males. Age, when we saw it, was maximum cases were in 0 to 10 years, and a second peak was in 50 plus, because they were the acquired cases. Etiologically, of the 42 cases, about 55 were acquired and 45 were congenital. Of the acquired, 60% were ischemic and about 40% were traumatic. We also had significant ocular deviations in cases of associated horizontal deviations in cases of congenital superior oblique palsy. About 37% had exotropia, equal number at esotropia, and pure vertical was seen in 32%. Examining the head tilt to the opposite side was seen in maximum, that is 60%, but head tilt to the same side also was seen in about 25% of cases, and chin up and down was seen in about 18% of cases. Recovery in acquired superior oblique palsy, about 70% recovered on their own, 22% required prism specs, and surgery was required in about 9% of cases. Of the 20 surgeries we did, 18 was for congenital and 2 were for acquired. 17 patients also required surgery for associated horizontal squints. Of the vertical muscles which we did for supraoblique, 55% required only one muscle surgery, that is most common muscle was inferior oblique. I just finishing off. 35% required 2 muscle, and 2%, that is 10%, required a 3 muscle surgery. So the post-op results were eyes were straight in about 64%, 33% there was a minimum deviation, and only one case we required a resurgery. So even the previous studies showed that the congenital palsies were 45 and 55% were acquired, and of the 23 acquired palsies in our case, 60% were ischemic, which was more or less similar incidence as the other studies. So this is all I've covered. So these are the pre-op photos of a case of acquired fourth nerve palsy. She had a small exotropia with right hypertropia and an significant X-cyclodeviation. And here we did a right inferior oblique recession with Harada-Ito to a right superior oblique and right lateral rectus recession, which corrected her exotropia as well as her vertical deviation and X-cyclodeviation. Now this is a case of congenital fourth nerve palsy showing a gross facial asymmetry with a right hypertropia and an overaction of right inferior oblique, and here just one muscle surgery, that is inferior oblique recession, corrected her hypertropia and head posture, though the facial asymmetry remains. So to conclude, trochlear nerve palsy presents a diagnostic difficulty to ophthalmologist not dealing with strabismus. Congenital and acquired were equal in our study. Spontaneous recovery was seen in about 60% cases of acquired palsy. Opposite head posture was seen in about 1/4 of patients. Surgical treatment was successful with only one patient requiring resurgery. Limitation of a study was small number of patients. And thanks for a patient listening.
So, Dr. Swangi, what is your carry home message to the audience?
Carry home messages, one has to keep that superior oblique palsy is also a fairly common palsy. Though the strabismologist, it is easy to diagnose, it's not very easy to diagnose for other ophthalmologists. And we have to make a case-based approach in a case of paralytic squint, depending on the merit of the case.
Thank you. Now I invite Dr. Jitendra Jethani to speak on low concentration atropine eye drops to control myopic progression in children's 4 years follow-up. Dr. Jethani, please.
Good morning. At the outset, I would like to thank Dr. Subhash Dedia sir and Dr. Yogesh Shukla sir for giving me an opportunity to present my work on low concentration atropine eye drops to prevent the progression of axial myopia in children. Atropine is being used in various formulations since almost 1960s. It has been used, and mainly it was atropine 1% drops. The problem with atropine 1% drops obviously was like photophobia and loss of accommodation, and we had to give bifocals and dark shades to the kids, and that is one of the reasons why it was not a very popular way of preventing the progression in children. Post ATOM 1 and ATOM 2 studies, especially from Audrey Leah and their group, they have showed that atropine 0.01% eye drops were equally efficacious as atropine 1%, slightly less than 1%, but they were doing the job. But there were no particular study in Indian eyes. And there have been a lot of theories. One of the first theories was that it blocks accommodation and reduces the action of accommodation on, and which accommodation may have an effect on progression of myopia, and atropine blocks it and helps in this. But since atropine 0.01% is doing a wonderful job, there were other theories which started doing rounds, because atropine 0.01% was not having much effect on the accommodation and on the pupillary size, as Dr. Leah showed in her studies. And so the current theory is that atropine may affect dopamine neurotransmitter release from cellular stores, and it may influence retinal signals that may control the growth of eye. So this is the current plausible theory. Our experience, we started using atropine 0.01% eye drops in children since 2013, and all the children who were with us in our OPD and had a documented progression of 0.5 diopters were included in the study, and the spectral power was between -2 to -10. This was I'm presenting the data of our longitudinal study, which was done on all the patients who came to the OPD were included. This was not a RCT. So axial growth and cycloplegic refraction was done at all the follow-ups. Mean follow-up was around 3.6 years. And how did we reconsider? So at that point of time, there were no atropine, low concentration atropine eye drops available. The good news is that now multiple companies have started making it. So there are now 3 companies which are making atropine 0.01% eye drops. So no more how did we reconstitute atropine, because we would now be using the commercially available 0.01%. We diluted them with lubricating eye drops, and a total of 358 children were taken. The mean age was 6.4 years, mean axial length before starting, the baseline axial length was around 23.62 millimeters. And in this particular data, we have included children who had at least 2 years of follow-up, and the compliance was also taken into consideration, not missing the drops for more than 2 to 3 days. Otherwise, rest of all the patients were excluded. They were not included in this particular data, although we tend to tell the patients that they should put, and so the major problem was that it is like a glaucoma therapy. It is a very long-term therapy, and sometimes patients stop putting drops. And at that point of time, we were reconstituting the drops, so they had to come to our clinic to procure them. So I think that would improve with the availability of atropine 0.01%. And a total of 64 children did not comply, and therefore we had only 294 children who were putting at least drops for 2 years or more. And so this was the results, and we saw that there was definitely a decline in progression of myopia, and over a period of 4 years we had around 368 eyes. So N is eyes, not the patients. And so you can see that there was, so this includes this includes all the patients. And so at the end of 4 years, there were some patients who were responding. There were some patients who had already were having high myopia, or their progression rate was much faster. So it depends on what is the progression rate. It comes down, and this is the mean growth which took place at the end of 1 year, 2 years, 3 years, and you can see that the growth has definitely, every year there is only 0.2 to 0.3 millimeter of growth. So that all depends, it varies. This is the mean, this is not the median, this is the mean. So it tells about the mean axial growth. It may include patients who were growing at a faster rate, it may include patients who are growing at a slower rate. This was the dioptric difference over a period of 1 year, 2 year. So this is 0.4 diopter 1 year, and at the end of 2 years that was 0.8. So again 0.4 per year. And the results were comparable. There was a publication last September, I think, by Dr. Mihir from Bombay. He published his data on atropine 1%, and he showed that atropine 1% was effective in Indian population, and the rate of progression reduced from 0.6 diopter to 0.2 diopter in his study. And that is the only known study in Indian eyes, but that is with a higher concentration. Obviously, there are small problems, with the higher concentration. ATOM-1 study was also done on atropine 1% eye drop, and they showed that there was a significant difference in progression of myopia. And ATOM-2 study, this is ATOM-2 study. This, the second one is ATOM-2 study, which shows that atropine in various formulations were equally effective. So may not be as good as 0.5%, but they were quite good, and they were showing good results. And the advantages of low concentration atropine is that there are minimal to almost no effect on accommodation. So there were only 6 to 8 patients who actually said that there was a problem, and then we told them to put the drops alternate days. And the chances of systemic side effects, which is also a major concern with atropine eye drops, like fever, flushing, are almost nil with such a higher dilution. the retardation of progression doesn't seem to be dose dependent. So we did not find it to be dose dependent. We don't feel that atropine 1% has a much higher role, because there were very few patients who could not, or who did not, who actually progressed. Even after putting atropine 0.01%, there were hardly 6 to 8 children who still progressed. And those children, we gave an option of putting higher concentration, but obviously they were not very comfortable with putting atropine 1% eye drops. So we conclude that atropine 0.01% eye drops, reconstituted eye drops, because we use reconstituted eye drops, are safe, and they are an effective option for preventing progression of myopia. It would need comparison with higher concentration vis-a-vis how good is a higher concentration vis-a-vis side effects of those higher concentrations, like effect on accommodation and photophobia. And we should also do more studies to find out indications for switching to higher concentrations. If the child is still having higher progression, we should be knowing what would be the indication to switch over to 0.1% or 0.5%. So this would require more studies to find out what would be an ideal concentration. Thank you so much.
Any questions to Dr. Jethani?
Yes, sir. This particular thing we studied mainly axial length and dioptric power. No, we did not study pupil size, not really, because we were not comparing 1% or 0.5%. We were just giving 0.01%. Yes, sir. I have not, but we have not compared in India. They have, that I said, it is already known. Yes. In that study they have also shown that there was more recurrence or rebound with atropine 1%. Yes. But sir, I was in my, what I meant was not with 1%. I meant was with 0.05%, 0.1%, like those. They have done it. But what I meant was that what would be the indication? So there were around 6 to 8 patients who did not respond to this. Yeah. So we have to go in depth whether it was parental myopia, which also Audrey has already mentioned that with parental myopia, if the patient is having a baseline higher myopia, these patients may not respond to 0.01%. Yes, yes. Yeah, so that is what is interesting in the theory part, but I think Jyoti is doing some study on tear concentration of dopamine levels at Narayan Netralaya, and they found that dopamine concentration, when it is higher, it is causing, when you put atropine, dopamine concentration actually increases in the tears. So we don't know what is going on at the scleral level or inside the eye. Yes. May not have those receptors. Very true, very true. Maybe, yes. We used it once a day and at the age of 5 years. We have not used in less than 5 years. And not beyond that also? No, 5 to 15 years, yes. In this particular data, we were only taking 5 to 12 years, but I don't think there should be a problem in using it for a higher age group.
What is the advantage of a commercially available low-dose atropine over a reconstituted atropine?
Lots, because no, it is not much of a difference. I mean, when you use a lubricating eye drop, it would be around a difference of 50 to 100 rupees, but you are getting a commercially available thing whose shelf life would be better, sterility would be better. You won't be knowing actually you are having 0.01% or 0.05 or 0.02. So, obviously commercially available will be much specific and much better drops. And legally, yes.
Available now in India, and by which company?
Yes,
and how much cost?
200 rupees. I think my Atro is 195 rupees and Myopin is 205, and now Sunways is coming with Atropine. So there will be 3 companies.
So with that we conclude this session, and there are 2 announcements. The midterms POSI meeting is on 19th May at Allahabad. Dr. S.P. Singh is the organizing chairman, so I request all of you to attend the midterms POSI at Allahabad. And Dr. Jethani, the annual conference is on 1st and 2nd December. So the annual conference of SPOCI is on 1st and 2nd December at Baroda, and Dr. Jethani is the organizing secretary for that. Thank you.
Check. குமார் ஆடி சரியில்லை.
Arjun, you also come, what? Arey, you have been the, come on. Aaja.